Thank you for joining me for another edition of Discover the Joy, the Purdy Podcast. We are back at UNF celebrating a year of the podcast, and I wanted to revisit these UNF researchers who you found so interesting. 14,000 people watched your episode, the original episode last year, because they wanted to hear how you were turning off these cancer cells. So I am going to play for them a little snippet from our original to explain how that process works.
So you are essentially getting a hold of the police officers in our bodies that are directing the traffic and directing things about how they're supposed to happen in our bodies. And there are some cells that are not listening to those orders, and those are the cells that turn into diseases.
That is partly true, yes. In this case, the police officer is not policing correctly. So the PRMTs that are supposed to mark certain parts of the DNA at certain times and have it function in a nice, well-oiled machine do not do it appropriately. And if they are overexpressed, they're going to mark these areas incorrectly, and they are going to either overexpress proteins that cause extra growth, which would be examples of oncogenes that can cause cancer, or they will shut down even proteins and their expression that can suppress tumors, called tumor suppressors, because they are also regulators of cell cycle or other mechanisms like that.
So these rule makers,
yes,
when they go on the fritz and they're telling cells to do wrong things, you are taking those rule makers and shutting them off.
That's right.
Yeah, I think that's fair. Yeah.
We could actively see the cells exploding through what we call programmed cell death or apoptosis. And we could see cells that were showing indication of another process called autophagy, where the cell thinks it's getting starved and kind of eats itself up. And so we're like, ooh, cool, that's fun. So my student loves watching those cells that look like they're eating themselves up because they're, cool. So we were like, ooh, that's fun. So, that was all well and good, but we were still worried that what if it does the same to normal cells? So then we worked together and we got some normal cells. I had a few with me, but we wanted to get some really primary cells that were straight from the body. We got a couple of cell lines and we examined them in there, and it didn't do the same to them. It was very targeted towards the cancer cells and not in the normal cells.
And if my memory serves me correctly, you were explaining that you were studying how PRMT1s, did I use that correctly? PRMT1s, how they affect the proteins in the body. And in studying that, you found a way to affect cancer cells. So I am itching to know, where are we now? There were a lot of things, a lot of goals that you had. So where are we now in the research? What has happened since the last time we talked? You had already gotten a patent. You were working on a second patent to hone in coverage over your idea. Are we there yet?
We did get approval for the second patent maybe a month ago.
Yeah.
So
That's awesome. Congrats. So what does this mean now? One patent does what and the other one does what?
one patent covers the ability of these compounds to kill cancer cells, essentially, so to turn off that part of the cancer. The other patent that we've most recently gotten is all about the actual compound itself and its structure and what it's made up of.
Okay, and I'm so excited I didn't even reintroduce you. We have Dr. Brian KNUCKLEY here, we have Dr. FATIMA REHMAN, and we have Dr. Corey Causey. Thank you. So, patents, that goal was accomplished. You also wanted to get to the point where you could take what you found and try it out on a living thing. So where are we there?
So that's work in progress. So if you remember, we talked a lot about how in a small school like UNF, where research is important, but maybe we are not quite where we have millions of dollars to our disposal, we have to be very careful in designing our experiments and making sure that everything that we design is going to give us meaningful data. So it took a lot of, kind of experimentation on our part to make sure that our compounds were working correctly, that our compounds were doing exactly what we wanted them to do, and then deciding the model system to test, how to look at it, what type of experiments to run, because there are many different ways that we can test it in an animal. And we can test many different types of animal. We could do it in something simple as flies or C. elegans, or we could do mammals like rats or mice or rabbits or something else. So it took a lot of us, like going through the literature, looking at what would be the best approach, what type of cell lines would we use, what type of cancer would we introduce. Before we decided on our approach, we've made that design. We have also engaged with company. We also thought about whether we should do it in-house or outsource it. And we decided that it would be best to outsource it to a company that can give us a little bit of an unbiased view, so to speak, right? So it's somebody who doesn't really care about our compounds. They are going to give us results just the way they get them. And then we can still get the samples and study them further and examine them further. So we approached different companies, we looked at those choices, we worked together to develop the experimental design. We have the experimental design in place, we have our objectives in place, we have secured the funding for that. We were lucky to get funding from one of the UNF systems, which is MedNexus, and we were able to get some funding from their innovation grant, so now we will be able to actually run those experiments through those companies.
And I remember the patents had a lot to do with that, because that kind of opens up by giving you, one, legitimacy, and number two, letting everybody know, hey, there is something going on here. The federal government has said they've got something.
Exactly, and that's very important, because until you have legitimacy, it's less likely to, secure the funding that we need for these more kind of in-depth experimentation. We also have a bottleneck of how much compound we need when you go into an animal system. When you're just putting it in a plate, you need a lot less compound than when you're putting it in an animal, no matter how small that animal is. So we are going to be running some mice studies, and that we know how many mice we're going to have and how many different portions of the experiments we need that for. We've calculated the drug. That's a large amount of drug to make. And so Dr. Knuckley and Dr. Corey have been working the whole year to make that drug in a more efficient way, in a more purified way, so that it is ready for those experimentation. And so hopefully we will be actually starting those experiments in the fall.
Okay, and I know, Dr. Causey, that's your specialty, taking it from a test tube into an actual living thing, taking a look at the molecules and how that's affected.
Right, so the synthesis of it is FATIMA. In the initial studies, we'd require, much smaller quantities, but now that we need more of it, the idea of efficiency became a much more critical factor, and so sort of refining the process and making sure that we get both usable quantities and in pure form, and so we've been doing a little bit of refinement on the production of the molecule itself.
So I have a question. So animals, you the last time mentioned mice, possibly zebrafish. How do you decide what animals to try this on?
So there are multiple factors that go into it. Cost is obviously one of them, but there are more important things like, do they have the PRMT1 in there working the same way as it is in humans? Do we see similar type of disease etiology in them as we do in humans? So do we see that PRMT1 overexpression leads to cancer in them, for example, right? And can it be categorically examined, and can we look at those signs and compare them to what we saw in cell culture or in humans? And so based on my expertise from before, which is in mice and rats, that meant that would be easier for me to deal with and easier for me to examine again, because I already have that expertise available.
Yeah, and you do the testing part.
Exactly, and zebrafish is something that would be a new model system for me that I would have to relearn. In addition, we have a lot of genetics already done on mice, and we have a lot of models available already in the market that are specifically designed for cancer studies, specifically designed with particular mutations in place. So it's a lot easier model system for us to work with.
So tell me, how soon are we looking at, you've decided on mice, how soon are we looking at testing this on mice?
So we think we'll be able to start that process in the fall. So right now we're on track to be able to have the large quantity of this compound available and ready to ship to the company, we think in September, October. and it's
That's like tomorrow.
Yeah,
don't remind us.
exactly. It's coming up soon, and that's what we are planning on doing. And my studies are in 3 different parts. So the first part is to actually just look at toxicity and see what is the largest dose that an animal can tolerate before it shows, effects on them in a harmful way or in a lethal way. So that would be our first study. Once that is done, then our second study is where we are taking some of you talked about model system as in mice or zebrafish. That's just one part of the story. The second is what type of cancer are we going to introduce in them? So based, again, on our research and what we know, we chose model system cell lines. One was a breast cancer cell line that we know expresses PRMT1 overexpression. And then the other one was a lymphoma cell line, and that also has many times been shown to show that overexpression. And so then they will look at those cell lines in the mice in a very particular way. There are different ways that you can run these studies. Some are more contained than others. So we're going to run them in a very contained way first and examine which one gives us more promising results or better results. And then eventually in the third phase, we will do actual tumor studies where we create these tumors in mice subcutaneously. So you use SCID mice that have no immune system. So they are able to grow these tumors when you inject these cancer cells in them. And once those tumors are large enough and you can actually see them and you can measure them, then we will introduce our drug in them and see how it affects that and how it actually kills them or not.
So what's the timeline for that kind of thing?
Each one of these, the toxicity study only takes a week or 2, but then we get the samples from them. We'll get the blood, the liver, different body parts once those animals are sacrificed, and we are able to then examine them and look at, section them, do immunohistochemistry, do different things to look at exactly what happened inside the body of an animal in response to the drug. Then in the second phase, again, each one of them by themselves can be as little as a week or 2, or on the longer end could be 45 days or even 2 months.
Okay, but we're not talking years.
No,
So
no, absolutely not. So this next academic year, we are hoping that we'll have all these studies done and their results analyzed and ready for the next step.
So less than a year.
Yes.
That should take. Mm-hmm. So, and the next thing somebody's going to want to know, you know what I'm going to ask. What about people? When do those clinical trials start? Or is there something else after the mice testing?
Again, when we go to clinical trials as well, the same problem arises. Now it's going into humans. That's even a larger endeavor. You need to create this product in an even more purified form and in a larger quantity. And that usually involves getting in touch with a pharmaceutical company that can actually take this and create that large amount that can be used in clinical trials. And once it gets to those clinical trials, the first phase is all about toxicity again. So it's similar to the same idea that you just saw. The same kind of things happen with phase 1, 2, and 3 trials, that they look at toxicity in general. They look at whether it is having any good, or causing no harm as such. And then they go into just testing it out by itself.
So the last time we spoke, you told me that this process could take anywhere between 5 years to decades. Yeah. Have you narrowed that down at all, at least to the people part?
Yes. Again, it is dependent on how the results look once we run the animal studies. And if they are promising, given today's technology and advancements and the global nature of our scientific studies, where we can have a lot, we can reach out to a lot more people, it could take just 5 years. It could still take up to a decade.
Okay, up to a decade, but that's okay. That's better than decades, which is what we said.
There are drugs that took 30, 35 years to get into clinics, so it's just the way that happens sometimes. That's the way they roll. And just because something gets into clinical trials doesn't always mean that they get approved either, even when they show positive results, unfortunately.
If they show positive results, why would they not want your study? Like, why would they not want you to continue?
Because sometimes there's a lot of competition in certain cancer fields. There are a lot more drugs that are coming out. There are lots of drugs coming out, and it becomes kind of like survival of the fittest in a way. So there are diseases, like, for example, the type of cancer I had, which was diffuse large B-cell lymphoma. They have a lot of different drugs available to people. They have a lot of different ways that it can be controlled. Some of them may cost a lot of money, but they are available. And they have a pretty high survival rate at the end of the day. A new drug coming in may not, the drug company itself may not even seek out that FDA approval even after getting positive results, because they think that they may not, they would have to invest a lot more money and time into it compared to if they use the same drug and focus it on an FDA approval for a cancer that does not have as much competition, does not have as many drugs available to them.
Okay. What I find unique about what you're doing is that when you were doing this testing in the test tube, it didn't affect good cells. I don't know about a whole lot of that out there. I mean, every time I turn around, somebody's taking a cancer drug, they get sick. There's some kind of bodily reaction. So to hear that you didn't find that, I mean, that's got to be a huge selling point, no?
It is. And there are lots of targeted therapies that are coming out. And yes, that is what they're looking for now, are these targeted therapies that do not cause the same kind of side effects that we have with traditional therapies. And that's important. And yes, that does give us an edge up. And of course, that does make it more likely to be actually in the clinic.
Now, how does this work? All of you had interns, students, helping. The season is over, school is out. Does the research go on pause for the summer?
He graduated.
Oh, hi.
I have a student back there working who graduated on Friday and is doing an experiment right now.
So it continues. You don't put it on hold.
No.
So you guys don't get a rest.
It's honestly probably the time of year where more research gets done.
Exactly.
Students are free, faculty have a little bit more time to dedicate to the research labs, and there's funding set up to support students throughout the summer to kind of be able to conduct that research.
Are you working with the same students?
It depends on their schedule. As they graduate and move on, some it's sort of a rotating, and some new ones rotate in, and so as others rotate out. So, it's part of as college students, part of their experience and learning. But it doesn't mean that, it's not as if it's a job or a career for them. It's part of the learning process. And so, as they move on, hopefully there's a pipeline of new students coming in to pick up where they left off, and it sort of continues.
I guess an even better question is, do you find the excitement of the students that are helping you still there?
I think, especially those who, when they see things like this and they see that there's press about it, they get in the excitement about it and want to be a part of it.
Yeah. Okay. And how do the students get credit? Do they get credit? Is it just class credit? Is he getting paid?
Unfortunately, not getting paid.
But
okay. Sometimes they
Sorry, I tried.
Sometimes they do. Sometimes we do have paid internships available where they do get credit in the form of payment. A lot of times it's in the form of the experiential learning that they're doing that shows up on their actual transcript as directed independent research. They also present at conferences, and that's great exposure for them, learning experience for them, and that's the way that they can get in touch with their future mentors and medical schools or whatever it is that they want to do next time. They also use this information again on their resume as well. They're learning skills that can directly relate to jobs that they would be looking for.
I love that you have found funding. I love that the research continues and that it's advancing and that we're getting toward the animal stage. These are all like huge updates, I feel. Are you all just as pumped about this? Do you still see this as a breakthrough, or are you seeing as you're going along, there's little hiccups here and there, and no, maybe not. I don't know. Like, how are you feeling about this? Because if you're feeling good, then I'm going to keep feeling good. So how do you feel about this? We'll start with you, Dr. Causey.
I would say I've been a scientist long enough to be cautiously optimistic about everything. There's always oftentimes people get to see the discovery side of things, but not everything that went into it and all the failure or setbacks or hiccups that come along with it. So I would say I'm cautiously optimistic. I can see progress in it, but I understand that there's a long road ahead.
Okay. Dr.
Same thing, that I'm cautiously optimistic. In my lab this year, we've been doing a lot of work on this compound, trying to understand its mechanism of action and looking at categorically one by one different hallmarks of cancer that it could possibly affect. And we've gotten mostly positive results, but we've also had places where we've been like, interesting. And we've looked at possibility of combining it with another drug to make it even more effective. So yes, there's definitely a lot of positive there, but cautiously optimistic.
Okay, we've got two cautiously optimistics. Dr. Knuckley?
I think it's exciting. I think anytime you have a research project that has some, that has, positive long-term outcomes, things that look fascinating, that sound like they may work, it's exciting. And I think too many times, like Dr. Causey mentioned, in science you have these hiccups, these things that come up where it doesn't work, and so you can be disappointed. No different than when we originally found this compound. It was through disappointment that we realized, oh wait, this is something good.
Something good.
So I think you always have to stay excited in science, and especially when you have a project that is fun and students, people are all motivated about. But I understand the cautiously optimistic as well. So.
Well, and I know you all are excited. Don't get me wrong.
No, we are excited, but like I said, and like he said, that there are always, you have to look at all the data and not just a small percentage of the data.
And last question for you, how are you doing? You are cancer-free. I remember we talked about that. So how is are we still good? Like, what's going on with you? If you don't
Hoping
mind
to
me
be good, but I did have some signals show up in March, and they are looking at it, and I'm having some surgery for it on Thursday to check it out to see if it is something to worry about.
Okay. All right. Well, I appreciate that update, and
thank you.
We'll be thinking about you on Thursday.
Thank you.
You beat it before, so
yes. Again, cautiously optimistic. I like that phrase.
Well, thank you all so much for the update. And do you mind if I check back in another year?
Sounds great.
That would be great. Hopefully, we'll have lots of
great results.
All right.
Then I'll be excited.
Then you'll be excited? Okay.
Then we will.
I'll remove some of the caution.
Exactly, we'll remove the caution.
Thank you so much.
You're welcome.
Dr. Rehman, thank you for allowing me to catch up with you by Zoom. You mentioned when we finished talking with you and the other researchers that you were waiting for a doctor's appointment to get an update on your own personal cancer diagnosis. How did that doctor's visit go?
So fortunately, it ended up being okay. It's reassuring so far. I actually had to get a biopsy after a recent PET scan, which is the way that they do surveillance for cancer after you're in remission and you don't have physical signs of cancer anymore, to just monitor and make sure it doesn't come back. And the last few times there had been a signal that had increased, so that was worrisome, obviously. And they decided to go in and take biopsies and check for recurrence. And fortunately, looking at the pathology, it looks like it's not a full-blown recurrence for sure. It may be a slow-growing lymphoma that they need to keep an eye on, but we're still waiting on some genetics to come back to let us know for sure.
Okay, well, you seem calm and you seem happy with that.
Yes, I'm relieved. There's a big weight lifted off our shoulders. We had a couple of weeks of really stressful time as we waited for the biopsy and then the results. I also had some just a weird, it's not one of the most common side effects, but it was a side effect of one of the medicines and the location that they were doing the biopsy in. The combination of that made me lose my sight for a few days, and that was extremely, obviously stressful. And we were panicked until we figured out that it wasn't a permanent thing. So yes, I feel better now.
Wow. And let's just remind everyone what type of cancer you had.
So I had a diffuse large B-cell lymphoma, and that is basically it's a type of blood cancer or lymphatic system cancer. Our lymphatic is responsible for our immune response, so it is obviously a big part of our body. And it's systemic, right? It's not like a solid mass normally that you can see physically and take out with a surgery. It's liquid in the lymph, and it can be anywhere. So that makes it a little bit different than typical cancers. And also just like a solid tumor, let's say you have breast cancer or brain tumor, if it spreads, it usually they look at, the lymph nodes first, right? And then they look at some other location. In my case, it's starting with the lymph and then it's going to another location. So original tumor had gone to my breast and some other locations in my neck. And this one was some signal that was showing up in my sinonasal cavity and in my lungs. So obviously same area, very easy to think that this would be a full-blown recurrence, and obviously very worrisome if that had been the case.
Oh my goodness. Well, I'm glad that the doctor used the words reassuring.
Reassuring.
It's
Yes.
so good to hear that. And now this is almost like deja vu because after our original episode, I caught up with you because I had found out that you had a cancer diagnosis. So I raced to get you on Zoom and you talked about being in remission. And you also talked about being on some new clinical trial drugs. So tell me about that. Did they help, these new clinical trials?
Yes. So when I was actually originally diagnosed with cancer, one of the first things they do is look at genetics of the cancer, look at what mutations are there, and then they kind of design the therapy for you based off of that. Because cancer is multifactorial, and even the same cancer in two different people will have different genetic background, genetic mutations. Some will be the same, right? There's some kind of a signature, but then there'll be other things. So you always have to tweak the plan. You can't just give the same drugs willy-nilly to everyone. So the mutations, the combination of mutations I had, would have made the traditional chemotherapy alone not be as responsive or as successful. They would have had a hard time killing my cancer cells, essentially, because one of the mutations in there actively stopped the cells from dying. And so the clinical trial that I was able to get on while concurrent with my chemotherapy was a drug, a very targeted therapy, kind of like the one that we are working on, where it specifically downregulated or suppressed that particular pathway in my cancer cells that was stopping the cells from dying and allowed the chemotherapy to actually work and allowed it to kill the cancer cells. So it was a godsend. I was the last person that was accepted into that clinical trial, actually. So I was extremely happy that I was able to get that spot and I was able to get that drug. And not just for me, but later on when they presented the results at a scientific conference recently, it showed that every single person that got that drug benefited from it as a result.
Wow, which is fantastic. So
Mhm.
hopefully this means what helped you will help others.
Well, one would typically hope that that's the next route. So this is a drug that is now FDA approved for several types of cancer as one of the targeted drugs that can be given concurrent with chemo or as by itself. However, the pharmaceutical company actually decided not to pursue the FDA approval for my specific type of cancer because there was a lot of competition, quote unquote, in that field with some other drugs that were available. And it has a relatively, it has other options available, kind of, so to speak. So they didn't think it was worth their time or money to go for that. Which actually initially when I found out made me cry for those people. And, I told my oncologist that sucks for those patients that would have benefited from it if they had the chance to get it concurrent with their chemo, because it would have saved them a lot of heartache, a lot of failures with failed chemo, and a lot more aggressive treatments that they would have had to gone through, like bone marrow transplant or CAR T therapy prematurely. This was a lot more simpler, easier on your body therapy that it by itself, other than some joint pain and some fatigue, did not really give me any side effects from this particular clinical trial drug. So I was kind of bummed that they weren't able to get FDA approval for diffuse large B-cell lymphoma as well.
So unfortunately, people who have your type of cancer will not be helped by this drug because it won't be.
Unfortunately not. Yeah.
But it will be available to others?
It will be available to others for other cancers where there is, a lot more need as well. Frankly, there are cancers that have really low survival rates. There are cancers that don't have a lot of targeted therapies or other options available. They cannot go through bone marrow transplant to help themselves. In those cases, this will be there and it will be able to help them.
All right. Are you allowed to tell me that what the
Yeah, I
drug?
can tell you it is actually available drug. It's parasaclisib. It's
Okay.
a PI3K inhibitor, so it is a very targeted therapy for a very particular type of mutation or set of mutations that activate a particular survival pathway. And this inhibits that survival pathway, kind of brings it down back to normal or below normal so that the cells can become sensitized to chemotherapy and other therapies.
Did they tell you which cancers it will go to help?
I, I know that it's for lung cancers. I can actually look that up right quickly. I forgot. I should have looked that up
Oh, that's
before.
okay. You don't have to do that now because I can do that, and anyone who's interested can do that too.
Yeah, but it is, you know, so one of the things with even lymphomas is that, there are slow growing lymphomas and there are fast, very aggressive lymphomas. So when I actually got my original diagnosis, it was obviously at that time extremely aggressive, fast growing lymphoma. But it had at some point transformed from a slower growing lymphoma, kind of like what we are waiting to hear back about now. And it is something that originally they actually developed it for these slow growing lymphomas that otherwise could not be given chemo or radiation. They are very resistant to those. And mantle cell lymphoma was another one that they worked on as well. But now, after clinical trial, it's been given for a lot of refractory diseases in lung cancer and prostate and some others.
Okay. And one more thing I wanted to ask you. You talked about side effects that you were still having even a year after remission. That's what you told me 10 months ago. Are you
Yes.
still having some of these side effects? And we're coming up on 2 years now.
Exactly. So, like we all the time, we look at people that have lost their hair and we look at that they are going through anemia and no immune response and all that during chemo. And we forget that some of these drugs, they're poisons, essentially, right? Traditional chemotherapy, if it's not a targeted drug, is killing your normal cells and actually mutating your normal cells, along with destroying the cancer cells. It's just doing the cancer cells a little more effectively. And so some of these side effects actually end up being long term. So, for example, the fatigue took almost a year and a half for me to feel like I'm back to where I used to be. My eyesight initially was affected where I didn't feel like I could, my brain fog, I had a lot of brain fog, but my eyesight itself, I didn't see as well as I used to. I never wore glasses. And I still don't wear glasses, but my eyesight is definitely not what it used to be. My brain, I could read very fast before. I could read and process information extremely fast. I could do a lot more kind of, where I was doing multiple things at the same time and not having any issues with it. I can't do that as much anymore. And that's permanent. At this point, I don't think it would ever return back to original. It's improved a lot. I can read. I can, think critically. I can respond to things. I can do everything that I used to, but at a slower speed. It takes me time to get. I have to give myself more time. Physically, I used to work out all the time. I can't do those things anymore the same way. The combination of drugs have affected my bones in a way that they are weaker. Some parts of them are kind of degrading and becoming osteoporotic, essentially, like an old person, right? I have severe pain issues, back pain issues that I'm essentially in pain all the time. And while that can be helped with therapy, with physical therapy, with, stem cells and all these things, it's never going to go away completely. It's just my new normal at this point. So there are long-term side effects that just you have to be aware of when you're going through these therapies. Obviously, as I tell my husband, I'd rather be in pain than dead. That's at the end of the day, that's my, balance. But I have to work harder to stay healthier and to make sure that I'm able to do all the things I would like to do and want to do.
Well, I hope folks take the time to go back and listen to the original podcast that you and the other researchers did with me, because you talked about using yourself as a guinea pig, basically to help your students learn more about how to figure out how cancers work. And I just find that remarkable.
Exactly.
And
That particular year, yes. And so in the following years, I have still used parts of that same kind of case study that I've developed at that point. Initially, like I said, as a processing mechanism partially, but I do use it, and that does help them see a different side of their learning. They see how it actually applies to real life situations and how they can use that to make more informed decisions, health decisions, medical decisions, whatever, about themselves and their loved ones.
Well, thank you. You're doing an awesome, awesome work. And I'm so excited to hear about the advancements that your compound is making. And I look forward to hearing an update. Hopefully, I'll be back in a year if that's okay.
Yes, that would be great. And, on that end, that is something that everyone should be aware of. Not everyone is a biologist, not everyone is comfortable with all the information that I know or that other people know about biology or medicine. But everyone does have the ability to find the resources to become healthier, right? And to have people around them that can help them achieve those goals. So for people that aren't biology or health information savvy, they can make sure that they have good, primary physicians that they are getting regular checkups with, and that they're getting checked out from, and doing all those screenings that are recommended at this point to make sure that any diagnoses like this can be recognized early enough so that they don't have to go through these debilitating, therapies with long-term side effects. My cancer itself could have been diagnosed at least 6 months earlier, and it wasn't. I had self-diagnosed it at that time, but it wasn't able to be diagnosed correctly until a lot later. Had it been diagnosed on time, I would have needed half, not even half, a third as much chemotherapy, and would have been healthier a lot earlier, and with a lot less chance of recurrence and a lot less spread. But we are mothers, and we are busy, and we are working, and we sometimes don't take the time to self-advocate and get to the doctor on time, or to get the tests that are recommended on time, to get that mammogram or colonoscopy, and we end up waiting too long. I have a colleague, a friend of mine, who had a lot of things going on in her family with her kids and didn't go to her first mammogram. By the time she got to it 6 years later, she had metastatic breast cancer. It had spread to her bones. It had spread to several places in her body. And at that time, then, I got it. There are advancements that will allow her to still live a few more years than it used to, but it wouldn't be that big, long life that she could have had. It would have been, severely shortened her lifespan because of that. So it's very important for us to take care of ourselves first, so we are able to be with our loved ones for longer.
Dr. Rehman, I feel like you were in my house literally like this weekend, because I got a letter from my doctor, both of those, colonoscopy and mammogram. They said, it's time.
That's important, to take care of yourself first.
I'm on it.
Yes, please.
Thank you so much. And folks, I hope you enjoyed this episode. Please make sure you like this video and subscribe so you can hear more inspiring stories like Dr. Rehman's and the other researchers as we continue on this journey of discovering the joy. Thanks, Dr. Rehman.
Thank you so much for the opportunity.